Awake fiber optic intubation is a technique used to secure the airway in patients who are awake or lightly sedated, utilizing a fiber optic bronchoscope to visually guide the placement of an endotracheal tube. It can be performed either orally or nasally. It is considered the gold standard for managing an anticipated difficult airway, particularly in elective procedures. Its primary purpose is to maintain the patient's spontaneous breathing and airway reflexes while securing the airway, thereby avoiding the risks associated with general anesthesia like hypoxemia and failed intubation. The indications of fiberoptic intubation can be grouped into anatomical, physiological, and special circumstance categories. Anatomical factors include a previous history of difficult intubation, restricted mouth opening, airway obstruction from pathology such as tumors, infections, or angioedema, and cervical spine instability due to trauma, degenerative disease, or rheumatoid arthritis. Physiological considerations include patients at high risk of aspiration, such as the morbidly obese, as well as critically ill patients with limited physiological reserve in whom the hemodynamic effects of induction must be avoided. Special circumstances include cases where immediate neurological assessment is required after intubation, since the patient remains awake and can be evaluated without interference from anesthetic agents. As with any procedure, awake fiberoptic intubation has specific contraindications, the most important being patient refusal or noncompliance. Other relative contraindications include inexperience, sensitivity to local anesthetics, and uncooperative patients such as children or those with special needs. Patients with a critical airway, such as those with stridor, are at risk of complete obstruction if a fibroscope is passed through the narrowest part of the airway. Similarly, fiberoptic intubation is not recommended in the presence of airway bleeding from trauma or tumor, as blood can obscure the visual field. Since we are dealing with airway, it is important to understand the relevant anatomy and its nerve supply. The upper airway is divided into the nasal and oral cavities, the pharynx, and the larynx. Sensory innervation of the upper airway is provided by the trigeminal, glossopharyngeal, and vagus nerves, which are essential targets when performing airway anesthesia for awake fiberoptic intubation. The sensory innervation of the nose is provided by the ophthalmic and maxillary divisions of the trigeminal nerve. The anterior ethmoidal nerve, from V1, supplies the anterosuperior internal nasal cavity and the anterior nasal septum, while the nasopalatine nerve and branches from the sphenopalatine ganglion, both from V2, supply the nasal septum and lateral nasal wall. The sensory innervation of nasopharynx comes from both the maxillary division of the trigeminal nerve and the glossopharyngeal nerve. The second division of the trigeminal nerve provides sensory innervation to the anterior and superior parts of the nasopharynx. Glossopharyngeal nerve provides sensory supply to the posterior and inferior aspects of the nasopharynx. The oropharynx is innervated by branches of the vagus, trigeminal, and glossopharyngeal nerves. The posterior third of the tongue, vallecula, and anterior surface of the epiglottis are innervated by the tonsillar nerve, which is a branch of the glossopharyngeal nerve. This nerve is also responsible for gag reflex. The posterior and lateral wall of the pharynx are innervated by the pharyngeal nerve, a branch of the vagus nerve. The anterior two-thirds of the tongue are innervated by the lingual nerve, which is a branch of the mandibular division of the trigeminal nerve. The larynx's sensory innervation comes primarily from two branches of the vagus nerve, the superior laryngeal nerve and the recurrent laryngeal nerve. The internal branch of the superior laryngeal nerve provides sensory innervation to the supraglottic region, including the epiglottis and the mucosa above the vocal cords. The recurrent laryngeal nerve provides sensory innervation to the infraglottic region, below the vocal cords and to the level of the carina.
Hello everyone and welcome back. In our last video, we went over the sensory innervation of the airway and why it matters. These nerves and the regions that they supply are exactly what we have to target when we prepare someone for fiberoptic intubation. The idea is simple. If we can block or numb those areas properly, we can prevent reflexes like gagging, coughing, or even laryngospasm, while still letting the patient breathe on their own. So in this session, we'll go through how we can numb or block the airway. Broadly, there are two methods that can be used. The first one is non-invasive, where we apply local anesthetics to the mucosa of the airway. This is called topicalization. The other one is the regional or nerve block techniques, where local anesthetics is injected close to the nerves. We'll look at them separately, but remember they often complement each other and can be used together. And since topical anesthesia is the most common method, we'll discuss it in this video. The most widely used local anesthetics is lidocaine. It comes in various forms and it's sometimes combined with vasoconstrictors such as adrenaline or phenylephrine to reduce the risk of nosebleeds, especially when the nasal route is preferred. The 4% solution and the 10% spray are the most commonly used preparations. Systemic absorption from topical application to the upper airway is lower than expected, so in practice, higher dose can be used. However, the maximum dose of lidocaine should not exceed 9 mg per kg lean body weight. That is why it is important to know about the strength of the drug that we are using and also the delivery devices that we are using. Cocaine is another local anesthetic that is used for topicalization. It is the only local anesthetic that causes vasoconstriction, so it makes it very useful in nasal topicalization. The problem with cocaine though is that it can strain the heart and raises blood pressure, so it should be avoided in patients with heart diseases or hypertension. There is also a mixture called Moffitt solution made with cocaine, adrenaline, bicarb and normal saline. This mixture is very useful because it gives anesthesia, reduces swelling and also shrinks blood vessels. Now, topicalization is not just about numbing the airway. We also need vasoconstrictors, especially when using nasal route, because the nasal mucosa is highly vascular. Bleeding can therefore occur during instrumentation, blocking the view through the fibroscope. On top of that, vasoconstrictors also reduces swelling and help maintain the patency of nasal passage. In this case, cocaine is particularly useful since it has natural vasoconstrictor properties. Other vasoconstrictors like xylometazoline and phenylephrine are often combined with lidocaine to provide both anesthesia and vasoconstriction. There are many techniques and devices that can be used to deliver the drugs that we have discussed. These include mucosal atomization device, the McKinsey technique, nebulization, and spray-as-you-go technique. Local anesthetics can also be directly sprayed from its container or used as mouthwash or goggles. We'll discuss the ones that are mostly used in clinical practice. A mucosal atomizer device converts a local anesthetic such as lidocaine into a fine mist or particles. This ensures that the anesthetic spreads over a large surface area, effectively reducing the dose while increasing the coverage. For deeper structures, a mucosal atomizer device with a longer malleable catheter known as laryngeal mucosal atomizer device can be used to deliver anesthetics. Just like mucosal atomizer device, McKinsey technique also creates mists or sprays of local anesthetics. It involves connecting a 20-gauge cannula to oxygen tubing via a 3-way stopcock. And through the remaining port of the stopcock, a syringe containing local anesthetic is connected. When the anesthetic is injected, the oxygen flow through it creates a jet-like spray, effectively dispersing the anesthetic. We can also use nebulizer to deliver local anesthetics into the airway. About 5 ml of 4% lidocaine nebulization for 10 to 15 minutes does a very good job. It is also well tolerated and topicalizes the entire airway including the trachea. This method is especially useful for patients with restricted mouth opening since other devices like atomizer can't easily be used. For deeper structures like vocal cord and trachea, we can make use of fibroscope's working channel. This method is called spray as you go technique. Through the working channel, a small amount of lidocaine can be delivered directly onto the vocal cord through a small tubing like epidural catheter. As the scope advances, local anesthetics can be deposited into the trachea. In practice, these methods are often combined. For example, we might use mucosal atomizers to topicalize the nasal mucosa, a spray for oropharynx, and the spray as you go technique for larynx and trachea. The exact choice is dependent on local availability of drugs and devices as well as clinical experience of using such devices. I'll discuss what I've practiced during my residency and also provide alternatives that can be used. For nasal topicalization, we used co-phenylkane spray in our institute. That's lidocaine 5% or 50 mg per ml with phenylephrine 0.5% or 5 mg per ml. Each squat is about 0.1 ml, so one spray delivers around 5 mg of lidocaine and about 0.5 mg or 500 micrograms of phenylephrine. Usually 3 to 5 sprays go into each nostrils. Alternatively, about 0.5 ml can also be given through mucosal atomizer device. Other options include 4% cocaine-soaked cotton soaps or Moffitt solution, nebulization of about 5 ml of 4% lidocaine, or Moffitt solution that is given through mucosal atomizer device. For topicalizing oropharynx, you used 10% lidocaine spray. Each actuation delivers about 10 mg of lidocaine or roughly 0.1 ml. One spray is applied to the base of the tongue, then one spray goes into each tonsillar pillar. In total, this usually requires around 4 to 6 sprays. Doing this numbs the tongue, soft palate, oropharynx where the gag reflex is the strongest. A mucosal atomizer with 5 ml of 4% lidocaine can also be used for topicalizing the oropharynx. As an alternative, the McKenzie technique with same volume of lidocaine can be used too. Another option is gargling viscous 2% lidocaine for 1 to 2 minutes. For anesthetizing larynx, the spray as you go technique is commonly used. Here, a 2% lidocaine is delivered through an epidural catheter inserted via the working channel of the fibroscope. Small amounts of lidocaine are instilled directly onto the vocal cord and trachea as the scope passes through. Typically, 2 ml is applied just above the vocal cord, followed by 2 ml below them. Alternatively, more invasive techniques like transtracheal block or superior laryngeal nerve block can be used, which we will be discussing in our next video. Hello everyone and welcome back. In our last video, we have looked at different methods of topicalizing the airway in preparation for fiberoptic intubation. In this video, we'll go through the regional blocks that are used for numbing the airway. The same diagrams here illustrates the sensory innervations of the airway. We have discussed it in the first video. In nutshell, we have three important nerves: trigeminal, glossopharyngeal, and vagus nerves. The nose and nasopharynx is supplied by trigeminal nerve, the oropharynx by glossopharyngeal nerve, and the larynx and trachea by vagus nerve through its superior laryngeal and recurrent laryngeal branches. There is, however, some overlap in these areas of supply, so the boundaries are not clear-cut, but this gives a good overall picture of the airway sensation. For anesthetizing nasal passage, topical anesthesia using sprays, nebulized anesthetics, or cotton swabs soaked in local anesthetics are effective. For oropharynx and larynx supplied by glossopharyngeal, superior laryngeal, and recurrent laryngeal nerves, topical techniques works well too, but we have the option of nerve blocks. These nerve blocks provides deep level of anesthesia but pose risk of injury to the nerve itself and adjacent tissues. They are also technically more challenging than topical methods. Let's begin with glossopharyngeal nerve block. The glossopharyngeal nerve provides sensation to the posterior third of the tongue and the vallicula, and also provides the sensory limb for the gag reflex. Therefore, this nerve block is particularly useful in abolishing the gag reflex. There are two approaches described for this block, intraoral and peristyloid approach. For the intraoral approach, the patient needs adequate mouth opening so that the posterior tonsillar pillars or palatopharyngeal arch is easily visible. The oropharynx also needs to be topicalized with lidocaine spray before attempting the injection. Then, using the tongue depressor to expose the posterior tonsillar pillar, we inject about 2 to 5 ml of 2% lidocaine submucously at the caudal aspect of posterior tonsillar pillars, approximately at about 0.5 cm lateral to the base of the tongue. The needle is then advanced only about quarter to half centimeters depth. We can use a 22 or 25 gauge needles, and it is important to aspirate before the injection. We then repeat it on the other side. Alternatively, a lidocaine soaked gauze may be applied firmly to the area for several minutes. This method reduces the risk of intravascular injection, but it is less reliable than direct infiltration. In peristyloid approach, which is an external approach, we inject local anesthetics just behind the styloid process. This is the area where the glossopharyngeal nerve runs. The internal carotid artery lies very close here, so careful technique and aspiration are essential. Moving on, the superior laryngeal nerve, a branch of vagus nerve, provides sensation to the laryngeal structures above the vocal cords and lies inferior to the greater cornu of the hyoid bone. Here it splits into internal and external branches. The internal branch then penetrates the thyrohyoid membrane, continuing submucously in the piriform recess. The external branch does not penetrate the thyrohyoid membrane. It descends on the larynx deep to the sternothyroid muscle. The superior laryngeal nerve can be blocked using the external or the internal approach. To perform the block using the external approach, the patient is placed in supine position with some degree of neck extension to facilitate the identification of the hyoid bone. Once identified, the hyoid bone is gently displaced to the site where the block is to be performed, and a 25 gauge needle is inserted from the lateral side of the neck, aiming towards the greater cornu. Upon the needle contact has been made with the greater cornu of the hyoid bone, the needle is walked off the bone inferiorly where 2 ml of 2% lidocaine is injected. This single injection will block both the internal and the external branches of superior laryngeal nerve. If the needle is advanced any further, it can pierce the thyrohyoid membrane. And injecting local anesthetic here will result in only the internal branch of the superior laryngeal nerve being blocked. As with all blocks, careful aspiration must be performed prior to the injection, especially as the carotid artery is in close proximity. The internal approach uses gauze or plaquettes soaked in local anesthetics and placed in piriform fossa using forceps. These gauze or plaquettes need to be kept in place for 5 to 10 minutes to allow sufficient time for the local anesthetics to take effect. Sometimes it can be difficult to identify the landmarks, for example in obese patient, when trying to perform this block. Ultrasound can therefore be used to facilitate the deposition of local anesthetics to the correct place. For this, the patient lies supine with the neck slightly extended and the high-frequency linear probe is placed across the neck at the level of hyoid bone. The hyoid bone appears as a bright curved line with a shadow underneath. The probe is then positioned in a parasagittal orientation just lateral to the midline. In this view, the structure visible from anterior to posterior are the omohyoid muscle, sternohyoid muscle, thyrohyoid muscle, and then the thyrohyoid membrane. Deeper to that is the pre-epiglottic space. The superior laryngeal artery may sometimes be seen here as well, but it is small and not always visible. After identifying these landmarks, a needle is inserted out of plane from anterior to posterior until we reach the plane just above the thyrohyoid membrane. Hydrodissection helps confirm the correct space. 1 to 2 ml of local anesthetic is injected into this space called the superior laryngeal space. This space lies between the hyoid bone above and the thyroid cartilage below and is bounded anteriorly by the thyrohyoid muscle and posteriorly by the thyrohyoid membrane and pre-epiglottic space. The sensory innervation of vocal cords and trachea is supplied by recurrent laryngeal nerve, also a branch of vagus nerve. Direct recurrent laryngeal nerve blocks are not performed as they can result in bilateral vocal cord paralysis and airway obstruction, as both motor and sensory fibers run together. Therefore, this nerve is blocked using translaryngeal block. For this block, the main objective is to identify the cricothyroid membrane, and to do this, the patient is placed supine with the neck slightly extended so that the landmarks become more prominent. The neck is then palpated carefully until the cricoid cartilage is felt, and just above this structure, lying below the thyroid cartilage, is the cricothyroid membrane, which serves as the target point. The trachea is then stabilized between the thumb and the third finger of one hand, while a 20 or 22 gauge needle attached to a syringe is advanced perpendicularly through the skin toward the membrane with continuous aspiration. And the sudden appearance of bubble confirms that the needle tip has entered the trachea. At this stage, 5 ml of 4% lidocaine is rapidly injected before the needle is withdrawn, and the resulting curve helps to disperse the anesthetic widely, thereby producing an effective recurrent laryngeal nerve block. For ultrasound-guided translaryngeal block, the probe is first placed in the midline of the neck in longitudinal orientation, where the tracheal rings appear clearly on the screen. As the probe is moved cranially, the cricoid cartilage comes into view, appearing slightly larger and lying more superficially compared to the tracheal rings, and with further upward movement of the probe, the thyroid cartilage is seen. The cricothyroid membrane is the structure that lies between the thyroid cartilage above and the cricoid cartilage below, and this is the target for our block. Once the cricothyroid membrane has been identified, the block is performed under real-time ultrasound guidance by gently tilting the probe from the midline into a parasagittal position while ensuring that the cricoid cartilage remains visible as a key landmark. The needle is introduced just cranial to the cricoid cartilage, and its path can be observed on ultrasound monitor. As soon as the air is aspirated, confirming entry into the trachea, the local anesthetic is injected to complete the block.
Having looked into airway topicalization and nerves block in our previous sessions, we will now dive into how we provide sedation for awake fiberoptic intubation. So, let's start with a simple question: why do we even need sedation, when topicalization or nerve blocks already do a great job of numbing the airway? Well, the short answer is, sedation makes the whole process a lot more tolerable for the patient. Being awake while someone is passing a scope into your throat is an anxiety-provoking experience. Sedation helps take the edge off that fear and anxiety, making the patient more cooperative. Now, one thing we always need to keep in mind is the depth of sedation. If we go too deep, we can tip the patient into apnea, and that's dangerous. Remember, we're doing awake fiberoptic intubation because the airway is difficult. If the patient stops breathing, we may not be able to ventilate or oxygenate them at all. By keeping the patient spontaneously breathing, we give ourselves a safety margin. It means that if the fiberoptic attempt doesn't work, we can pause, step back, and consider another option, like an awake tracheostomy, without losing control of the situation. When we talk about sedation, it's important to remember that sedation exists on a continuum. A patient can drift from mild sedation into moderate, from moderate into deep, and if we're not careful, they can slip right into general anesthesia. We define sedation level using 4 parameters: responsiveness, airway control, breathing, and cardiovascular function. If we look at this table, we can appreciate that breathing and airway is maintained only during minimal and moderate sedation. Beyond that, in deep and general anesthesia we more likely need intervention on our part to maintain airway and support ventilation. So for awake fiber optic intubation, we aim to target the sedation at the first 2 levels where the patient is responsive to verbal or tactile stimulation. Regarding the drugs used for sedation, they generally fall into 2 categories: those that are primarily anxiolytic, and those that are mainly analgesic. Some of the newer agents actually have both properties, which makes them very useful. The common drug classes include benzodiazepines like midazolam, opioids such as fentanyl and remifentanil, alpha-2 agonists like dexmedetomidine, and of course ketamine and propofol. Drugs that provide both anxiolysis and analgesia are usually preferred for awake fiberoptic intubation. In practice, we often combine agents to achieve this. For instance, a small IV dose of midazolam or a low-dose propofol can help reduce anxiety and give some amnesia, while an opioid or a dexmedetomidine infusion provides analgesia and light sedation. The most important point is to titrate carefully, aiming for a level where the patient still responds to commands or gentle stimulation. Dexmedetomidine is one of the preferred choices for awake fiberoptic intubation. It works as an alpha-2 agonist, which means it provides sedation, reduces anxiety, and even adds some analgesia, but the real advantage is that it doesn't depress breathing. Patients remain cooperative and can still follow simple commands, which makes it ideal for this setting. In terms of dosing, we usually give a loading dose of 0.5 to 1 microgram per kilogram over 5 to 10 minutes, followed by a maintenance infusion of 0.2 to 0.7 micrograms per kilogram per hour, titrated carefully to effect. Another benefit is that it helps keep heart rate and blood pressure more stable, and it reduces secretions, which makes the whole process smoother. That said, we do need to be careful. Bradycardia and hypotension can occur, particularly if the loading dose is given too quickly. Remifentanil is another very useful drug for awake fiberoptic intubation. It's an ultra-short-acting opioid, which means it comes on very quickly and also wears off just as fast. The reason we like remifentanil is that it gives strong analgesia and, at the same time, suppresses coughing. This makes it much easier to pass the scope smoothly through the airway. We can give it in 2 main ways. One is as a target-controlled infusion, usually set at about 1 to 4 nanograms per milliliter. The other is as a continuous infusion, typically around 0.05 to 0.1 micrograms per kilogram per minute. But there is a risk. If the drug is pushed too fast, patients can become apneic, and in some cases even develop chest wall rigidity. So the key is to start low, titrate slowly, which is easy because it doesn't accumulate in the body. Another limitation is that remifentanil doesn't provide much in the way of amnesia. Patients may still recall the procedure, which is why we often pair it with a small dose of a benzodiazepine for comfort. Fentanyl is another opioid that's widely used for awake fiberoptic intubation. Its onset is fairly quick, usually within 2 to 3 minutes, and the effects last around 30 to 60 minutes. This makes it very useful for providing pain relief and suppressing coughing while we pass the scope. In practice, we usually give fentanyl as small intravenous boluses, around 25 to 50 micrograms, titrated carefully to effect. One limitation compared to remifentanil is that fentanyl is longer acting, so once the dose is in, we can't adjust it as precisely. That said, fentanyl is widely available, and familiar to all of us. Like remifentanil, there is a risk of apnea or even chest wall rigidity if given too quickly. Another point is that fentanyl doesn't provide much amnesia, so patients may still remember the procedure. For that reason, we often pair it with a small dose of midazolam to improve patient comfort. As we've already discussed, benzodiazepines like midazolam are primarily used for anxiolysis and amnesia, helping to prevent the patient from remembering the procedure. Midazolam specifically is a short-acting benzodiazepine. In adults, an initial dose of about half to 2 mg intravenously, given slowly and titrated to effect. Unlike opioids or dexmedetomidine, midazolam doesn't provide any pain relief, so it's typically combined with an opioid such as fentanyl or remifentanil. We also need to be careful with dosing, because overdosing can lead to respiratory depression. Other benzodiazepines, like low-dose diazepam, are used less often due to their longer duration of action. Just like dexmedetomidine, ketamine provides both sedation and analgesia. It creates a dissociative state, and the major advantage is that patients usually maintain their airway reflexes and continue to breathe spontaneously. For awake fiberoptic intubation, we generally give it as a low-dose intravenous bolus, about 0.2 to 0.5 mg per kilogram, and if needed, small boluses can be repeated. One additional benefit is that ketamine causes bronchodilation, which is particularly useful in patients with reactive airway disease. On the downside, it increases secretions, so we usually give it together with glycopyrrolate. It can also cause emergence phenomena, but this is much less of a problem if it is combined with a benzodiazepine. Propofol is another agent that sometimes comes up in the discussion of awake fiberoptic intubation, but its role is actually quite limited. The main reason is that propofol, while being an excellent sedative and hypnotic, does not preserve airway reflexes or spontaneous breathing. In fact, it often suppresses both very quickly, which makes it less ideal for a truly awake intubation. If propofol is used, it should only be in very carefully titrated, small doses, usually as a slow infusion, around 25 to 50 micrograms per kilogram per minute, rather than a bolus. Some anesthesiologists keep it as a backup, giving tiny boluses of 10 to 20 milligrams if the patient becomes too anxious or uncomfortable. So, to wrap things up, when we're choosing sedatives for awake fiberoptic intubation, the main point is that a combination of anxiolysis and analgesia works best. Drugs like propofol, or other 4-hypnotics, are usually avoided on their own because even small doses can abolish airway reflexes and potentially cause apnea. One important takeaway from recent evidence is that there isn't a single best sedation regimen. What really matters is picking an approach that you can titrate safely. Even more important than the choice of drug are the basics like good technique and maintaining oxygenation. At the end of the day, it comes down to using agents you're familiar with and applying them carefully. Though not a sedative agent, we must mention glycopyrrolate as a premedication or adjunct during awake fiberoptic intubation. Glycopyrrolate works by blocking muscarinic acetylcholine receptors, so essentially it reduces salivary and airway secretions. One of the big issues during the procedure is excessive secretions, which can fog up the scope and make intubation more difficult. We usually give it intravenously, about 0.2 milligrams, around 15 to 30 minutes before we start. What's particularly nice about glycopyrrolate, compared to atropine, is that it doesn't cross the blood-brain barrier. So it doesn't cause sedation or central nervous system side effects. It also has the added benefit of reducing bradycardia, which can occur with sedatives like dexmedetomidine or opioids. And in practice, glycopyrrolate is especially useful when we're using ketamine, since ketamine on its own tends to increase secretions. In the previous videos, we have covered airway topicalization, nerve blocks, and sedation for awake fiberoptic intubation. In this video, we will focus on the key instrument at the heart of this procedure, the fibroscope. A fibroscope is a handheld device made of fine glass fibers bundled together. These fibers carry light down to the tip to illuminate the airway and bring the reflected image back so the operator can see the structures ahead. In modern practice, the fibroscope is connected to a video system, projecting the image onto a screen for a clear, enlarged view that the whole team can see. There are three important parts of a fibroscope that we need to know to use it effectively: the eyepiece or camera, the angulation lever, and the working and suction channels. The eyepiece of the fiberoptic scope is the part through which the operator directly views the image carried back by the fiber bundles. It magnifies and focuses the airway structures, allowing clear visualization during intubation. Focusing is done using the diopter adjustment ring around the eyepiece. While modern scopes usually connect to a video camera and monitor, the eyepiece is still important as a reliable backup if the video system fails. Next, the angulation lever is located on the back of the handle and is operated with the thumb. When the lever is pushed down, the tip of the fibroscope bends upward, and when the lever is pulled up, the tip bends downward. This mechanism allows precise control of the tip, which is crucial for guiding the scope smoothly around the curves of the airway. It's important to note that the angulation lever only provides up and down movement of the tip. True side-to-side or lateral movement is achieved by rotating the entire scope by hand. Finally, the working and suction channels run along the scope and both open at the distal tip. Through these openings, we can suction secretions, deliver oxygen, spray topical anesthetics, or even pass instruments like catheters and guide wires while the scope remains in place. In smaller scopes, the two channels may be combined into a single multipurpose channel. Apart from the three main structures we already discussed, another key part of the fibroscope is the cord. This is the long, flexible shaft that connects the handle to the distal tip, and it's the part that actually enters the patient's airway. A larger diameter cord means more bundles of fibers inside, which improves the image quality. It also allows for bigger working channels, which makes suction and instrument use more effective. But when we use the scope for intubation, the scope has to fit comfortably into the airway, and it must also allow an endotracheal tube to be railroaded over it. That's why we match the external diameter of the scope with the internal diameter of the tube. As a rule of thumb, the endotracheal tube should be at least one size larger than the fibroscope. For example, a 5 mm tube will fit over a 4 mm scope. In adults, the fibroscopes we commonly use are between 4.5 and 6.5 mm in diameter. To successfully intubate with a fibroscope, you need to be familiar with the basic scope movements. The good news is that there are only three main movements: handle rotation, tip flexion, and cord insertion or retraction. Handle rotation means rotating the handle to rotate the tip, which is mainly achieved by flexing and extending the wrist rather. Tip flexion is controlled by the angulation lever, where pulling it down makes the tip go up and pulling it up makes the tip go down. Cord insertion or retraction is done by the other hand, which gently pushes or pulls the cord to advance or withdraw the scope. By combining these three movements, we can guide the scope smoothly, even around curves. Successful maneuvering of the endoscope relies on the three-step rule: stop, center, and move. Once the scope has entered the airway, it is important to stop and identify the target before proceeding. After identifying the target, it should be brought to the center of the field of view using the three basic scope movements, and the scope should not be advanced until this is achieved. Only when the target is centered should the scope be advanced, and if the target moves out of the center, the process of stopping, centering, and moving should be repeated. Several tips can make scope handling easier. The endoscope should be kept straight to avoid loops, since loops reduce tip control. Adjusting the operator's position or bed height may help. All movements must come from the wrist, not the shoulder, as shoulder use reduces control and promotes loops. There are several videos on YouTube demonstrating how to handle and maneuver a fibroscope. These provide a more complete visual guide to its use than can be covered in this video, so it's highly recommended to refer to them for practical demonstrations. We have covered several videos in the previous sessions discussing various aspects of fiberoptic intubation, including airway anatomy, topicalization, sedation, and the working mechanism of the fibroscope. In this video, we will discuss how to actually perform the fiberoptic intubation step by step. The first step is to obtain the patient's consent and clearly explain what will happen during the procedure. It is important to tell the patient that their airway will be numbed using local anesthesia so that they will not feel pain. They will receive light sedation to help them stay relaxed, but they will not be completely asleep. This explanation helps to reduce fear and anxiety and builds confidence between the patient and the anesthesia team. It is also at this stage that an anesthesialagogue such as glycopyrrolate or atropine is given to reduce airway secretions, which improves fiberoptic visualization and enhances the effectiveness of topical anesthesia. Glycopyrrolate is preferred for its minimal effects on the heart and the central nervous system and is administered as 0.2 to 0.4 mg intravenously. Along with preparing the patient, it is equally important to prepare all necessary equipment, drugs, and the entire team. Using a structured checklist, such as the one recommended by the Difficult Airways Society, ensures that every essential item and backup plan is in place. The checklist confirms the availability of all equipment and backup devices, clarifies the roles of each team member, ensures an extra anesthetist is available to provide sedation, and guides the optimal positioning of personnel and equipment during the procedure. Two positions used for awake intubations are the semi-recumbent or sitting position and the supine position. In the semi-recumbent position, the patient sits upright and the operator stands in front of them, which is preferred for patients who are dyspneic or have maxillofacial trauma because it allows better communication and is less intimidating. In the supine position, the operator stands behind the patient at the head of the bed, which is comfortable for many anesthesiologists and provides easier access to the airway. In both positions, aligning the operator, equipment, and monitor in a single line of sight minimizes head movement and optimizes ergonomics. The picture shows the position of equipment relative to the patient and operator. Specifically, the screen displaying the fiberoptic image should be positioned directly in front of the operator. During fiberoptic intubation, maintaining adequate oxygenation is critical because the procedure can sometimes take longer, and sedation or airway obstruction may reduce the patient's spontaneous breathing effort. Several techniques can be used to ensure continuous oxygen delivery throughout the process. Oxygen can be administered via standard nasal prongs or a nasopharyngeal catheter and face mask. High-flow nasal oxygen is particularly effective, as it delivers a continuous flow of humidified oxygen and provides a small degree of positive airway pressure, which helps delay desaturation. The next step is anesthetizing the airway to desensitize the nasal, oral, pharyngeal, and laryngeal mucosa. We have discussed airway topicalization and nerve blocks in detail in our previous video. The goal is to achieve patient comfort and suppress cough and gag reflexes while maintaining spontaneous breathing. After airway anesthesia, the next step is sedation, if indicated, followed by the actual fiberoptic intubation. Again, we discussed the inner workings and the usage of fibroscope in a separate video. So how do we perform an awake fiberoptic intubation? There are several techniques, but let us go through the method described by Nisora, step by step. The patient should be positioned as upright as tolerable to help maintain airway patency and comfort. If the patient cannot sit up, the procedure may be performed in the supine position. Supplemental oxygen is administered throughout the procedure using a face mask or nasal cannula. Standard monitoring, including electrocardiography, pulse oximetry, and non-invasive blood pressure measurement, should be attached. Glycopyrrolate, at a dose of 4 micrograms per kilogram given intravenously, is administered to reduce salivation and improve visualization during the procedure. The Nisora technique uses target-controlled infusions of remifentanil at concentrations between 1 and 3 nanograms per milliliter and propofol at 0.5 to 1 microgram per milliliter. These doses are carefully titrated to achieve a calm, cooperative patient who maintains spontaneous breathing and can follow commands. There are many other sedative agents that can also be used, but the key principle is to maintain a balance, providing enough sedation for comfort while keeping it light enough to preserve protective airway reflexes and spontaneous ventilation. After sedation, we can proceed with topicalization. Begin by anesthetizing the nasal passages and nasopharynx. Moffitt's solution, a mixture of lidocaine and adrenaline, is sprayed through a mucosal atomizer device to provide both anesthesia and vasoconstriction. Alternatively, cophenolcaine spray can be used, with approximately 2.5 milliliters applied to each nostril. This step helps minimize bleeding and discomfort during fibroscope insertion. For the oropharynx, we use 10% lidocaine spray is commonly used. Each actuation delivers about 10 milligrams of lidocaine, roughly 0.1 milliliters. One spray is applied to the base of the tongue, then one spray on each tonsillar pillar. In total, this usually requires 4 to 6 sprays. This numbs the tongue, soft palate, and oropharynx, where the gag reflex is strongest. For deeper structure like the vocal cord, we can make use of fibroscope's working channels. This method is called spray-as-you-go technique. Through the working channel, a small amount of lidocaine can be delivered directly onto the vocal cords through a small tubing-like epidural catheter. As the scope advances, local anesthetics can be deposited into the trachea. This targeted application suppresses coughing and makes advancing the tube much smoother. Preparing the fibroscope involves preloading an endotracheal tube, usually 6 or 6.5 millimeters in internal diameter, onto the fibroscope. As a rule of thumb, the endotracheal tube should be at least one size larger than the fibroscope. We must also ensure that the light source is bright, the lens is clean, and the scope is well lubricated. Following this, we have to insert the fibroscope gently through the anesthetized nostril or mouth, depending on the route we choose. We need to advance it under direct vision, carefully identifying key structures such as the turbinates, nasopharynx, epiglottis, and vocal cords. As we move the scope forward, we should use the spray-as-you-go technique, applying small aliquots of 1 to 2 milliliters of 2% lidocaine through the working channel. This helps keep the patient comfortable and suppresses cough or gag reflexes. Once the vocal cords are clearly visible and open, we have to advance the scope through them into the trachea, making sure to visualize the tracheal rings and carina to confirm correct placement. Next, we have to railroad the lubricated endotracheal tube gently over the fibroscope and advance it into the trachea. Once the tube is positioned, we should visualize the carina through the fibroscope to confirm that the tube has entered the trachea correctly. The fibroscope is then withdrawn carefully, the cuff is inflated, and the anesthetic breathing circuit is attached. We confirm correct tube placement by observing capnography, chest expansion, and bilateral breath sounds. Once we have confirmed that the endotracheal tube is correctly positioned and the patient is breathing adequately, you can safely proceed to induce general anesthesia. At this point, the airway is secure, and the patient is protected. In summary, to successfully perform awake intubation in a patient with an anticipated difficult airway, we must have a thorough understanding of and be competent in several key areas. These include knowledge of the innervation of the upper airway, familiarity with the appropriate local anesthetic techniques and vasoconstrictor drugs, and mastery of the methods used to topicalize or anesthetize the upper airway. We must also be skilled in prudent sedation techniques and in maintaining adequate oxygenation throughout the procedure. In addition, it is essential to understand and perform the techniques required for correct endotracheal tube placement. Mastery of these components ensures that awake intubation is performed safely and smoothly, with minimal stress and a high level of patient comfort and satisfaction.